We are super excited to welcome our speaker today, Dr. Christina Olson, who is going to be presenting to us virtual precepting, incorporating learners into telehealth and patient care. Dr. Christina Olson is the telehealth curriculum director and a pediatric hospitalist at the University of Colorado School of Medicine and the medical director for telehealth at Children's Hospital Colorado. Her interests include optimization of patient and health system outcomes across the healthcare spectrum, healthcare in areas with less resources, and medical education. As a founder of Sprout, a telehealth research network, and co-principal investigator for the NIH-funded Sprout CTSA Telehealth Research Collaborative, she also advocates for evidence-based growth of telehealth and the inclusion of virtual tools in clinical research. I feel really fortunate in that we were able to recruit Christina several years ago to develop and direct our telehealth curriculum, and that became a clear necessity in our School of Medicine at the beginning of the pandemic, and she's done a tremendous job in that role. And that continues to be one of our core curricular goals moving forward. So I can go more into that.
Right. So I intend this to be relatively informal because this is a topic that I think can be overwhelming for people who aren't used to it, but at the same time, it's actually really not, and we'll talk about why. So I have no financial disclosures. This is the Sprout grant that I just wanted to mention, and we do have an education working group, which I partially work with, and I've managed to get some of their content as well. All right, so objectives. We want to talk about the learner and preceptor experience and best practices for that. We actually want to talk about a framework for how you approach these visits. And then we're actually going to go through the 1-minute preceptor model. I'll explain why I chose that one particularly and why I love it for virtual care, and actually show for both novice and experienced learners how you can use this model when you have learners in telehealth care. But the first question is why? I don't think, hopefully for most people, I don't need to explain why virtual care is important, but I think that there's not necessarily an understanding of why we actually need to do this for education, other than that students want it, but it actually is really important. So I'm going to spend a little bit of time actually talking about the word imperative, and I chose that very intentionally here. I really do think it's an imperative, not just because I'm biased for virtual care, but because I think this actually is important for our learners. And I'm using the term learners here to incorporate everyone from medical students, nursing students, students of all healthcare professions, on up to fellows, and even junior faculty. So the word learner here is intended to be very inclusive, not very narrow. All right, so background. Hopefully this is not a surprise to you. I just pulled our children's data. Before the pandemic started, telehealth accounted for less than 1% of ambulatory volume. In a good week, we had about 100 telehealth encounters per week. Currently, 2 years later, more than 2 years later, we've actually stabilized out around 10 to 15% of ambulatory volume being done virtually. We went obviously much, much higher early in 2020 at the start of the pandemic. But what this means is that 2 years later, this is probably steady state. There's going to be some ups, there are some downs. We have ups during snow season. We have downs maybe during summer. But this is probably where we're going to be, which means our learners need to know this because this is going to be part of their future practice. Faculty may be able to say if they're near the end of their career, maybe they don't need to spend a whole lot of time learning virtual care. But for our learners, this will be a part of their future practice. At the same time, the reason I want to talk about precepting is because this has been very scary for faculty. And part of it is because we've overlaid the pandemic and all the changes that happened with it, all the emotions that we're still dealing with. And then we threw video visits at everybody. But this data came from May 2021, so about a year after the pandemic started. And faculty at Children's actually reported that about 50% of them felt that the expansion of video visits in their clinical practice had a negative impact on their experience teaching learners. And there's a lot of factors behind this, scheduling, other things like that. But I do think one of it is that we haven't actually taught faculty how to incorporate learners into virtual care. We haven't taught them how to be comfortable with it, how to actually be an effective preceptor in that space. And by the way, that's why I'm here today. Along those lines, most of our faculty across the board, not just pediatrics, have had very minimal training on virtual precepting. And our learners, they're very interesting because their needs are different than our faculty. So when I'm teaching telehealth to faculty, I'm focusing on how to use the Zoom type environment, other things like that. When we're teaching to learners, most of them are very, very comfortable online. In fact, they can teach us a lot about this. Their ability to get verbal communication through online is outstanding. They're very comfortable in that space. In some cases, maybe even a little too comfortable because it's how they communicate with family members. And what we have to be talking about is how you actually take that to the very different, and I don't want to say rigid, but a little more organized, controlled patient care environment. Which means they also, though, do have less understanding of other aspects of virtual care, and the ability to communicate with grandmother, mother, whomever on FaceTime is not the same thing as being able. Do I need to move closer? Okay. That's hard on address. Okay, we'll try with this. But they may not know how to do virtual exam skills. In fact, they're still learning just clinical exam skills across the board. And so there is still a reason to be teaching this to our learners who are very comfortable online. And if this isn't just, like I said, my bias, the AAMC came out with telehealth competencies. Interestingly, they, by random chance, were released a couple months after the pandemic. And so I think people thought that these competencies were released in response to the pandemic. That's actually not true. These were in development for about 3 years before the pandemic. They were about to release, and then COVID happened, and so they were actually ready to go. They sped it up a little bit at the end, but there's about 2 to 3 years of significant work and educational expertise that went into these competencies. And they came out with 6 domains. I put them up here, but then they put out 3 physician development stages. So what this looks like, and I just pulled this from their website, for each of the domains, they came up with a table that looks like this. So this is the one on patient safety and appropriate use of telehealth. So you notice there are 3 phases. And then they show what actually would be considered appropriate competencies for each of those phases on this matrix. And again, they've done this for 6 domains. But this is also important because of professional society. So I stole from my own American Board of Pediatrics, where I am board certified. In the past 6 to 12 months, they actually came out with a supplemental entrustable professional activity, also known as an EPA, which is kind of like their competencies, what they expect from people who are going to be board certified. Note, this is still supplemental. That might not be supplemental in the future. If you actually see, it's very, very similar to what the AAMC put out, rearranged a little bit into knowledge and clinical skills. Knowledge, obviously, the ones that are listed here, clinical skills, the communication, the exam techniques, and medical decision-making, patient management, and follow-up. Communication, by the way, includes rapport building, which we're going to talk about a little later, not just actually talking on Zoom. And by the way, I'm using the word Zoom here just because it's common, and that's what we're on for this grand rounds. But to be clear, there are a lot of different telehealth platforms out there. Zoom is one of them. Sometimes it's HIPAA compliant, sometimes it's not, depending on the organization. There are other ones like video and others. So just please pick your favorite platform when you hear me say Zoom. So I mentioned what the boards are talking about. I mentioned what the AMC is talking about, but the ACGME is actually getting into this too. And in December, the family medicine people in the ACGME actually proposed new additions to the residency curriculum, meaning what is expected to be taught. This is no longer supplemental if this goes through. This would be core if it's approved. And they want to say that residents should be able to demonstrate competence in appropriately using technology to provide accessible care, i.e. via telehealth, and note independently. They actually also then later on say that resident patient encounters should include telehealth and e-visits. And so again, this is not approved yet, but if this does go through final approval, this will be something that family medicine curriculum will be looking at, along with probably other residencies too. I'm just using examples here. So then let's talk more locally. So as Dr. Adams mentioned, early in the pandemic, the School of Medicine, specifically the medical school, decided that telehealth was a necessity. And so a basic curriculum was developed. And part of this was because actually the clinical training sites require telehealth education as a condition for students to return to clerkships. Once COVID, we started getting back into in-person learning. And it's important to note, again, we're talking about all the educational side, but our clinical training sites are places where we're privileged. They can actually put on telehealth requirements. They can expect things of faculty, of learners, whatever. And so we need to teach them if we want them to participate in clinical care at those sites. The faculty actually reported very high stress in learning to care for patients virtually, but also lack of tools in integrating students into the virtual environment. And yet, oh my gosh, there's positive here because there was also incredible tenacity, incredible flexibility. The fact that it actually happened in about 1 week's notice is nothing short of amazing. So everybody should be applauding themselves for that. Where this is coming from though, so that's where we were early pandemic. We have long-term goals though, and one of them, which I'm working on, is to integrate telehealth into longitudinal curriculum guided by those competencies from the AAMC that I already talked about. And ultimately the goal, and I'm just gonna read this because I think it's important, is to prepare students to practice today, tomorrow when the benefits of telehealth can be realized for all members of society, and then in the future when, for whatever reason, we need to adapt again, and I'm sure there will be a reason somewhere down the road. Achievement of this, though, depends on having faculty who are well equipped to precept in the virtual care space, because I can do didactics, I can do teaching for students, but where students are going to be learning and residents and fellows, they're going to be learning from their preceptors elbow to elbow in the clinical care space. And so what we really need to do is train faculty. All right, and then lastly, I want to talk about what the residents and fellows think they need. So the clinical learning environment review by the ACGME for this campus, primarily for UCH site, was done in September 21. And interestingly, for the first time, it included a huge section on telemedicine. A lot of findings in there, but I wanted to talk about what they actually heard from the residents and fellows. The residents and fellows were we're requesting education on determining which patients are appropriate for telehealth, virtual exam skills, how to maximize virtual visits when exam is not possible. This really means it during phone visits, by the way, and the legal aspects of telehealth care. For example, can they record? Can parents record? Can patients record? And then licensing and things like that. So this is actually what our residents and fellows want to know. And again, note that was September 2021. So that wasn't the beginning of the pandemic. That was after they had already been in this space for about a year. So hopefully I have demonstrated the imperative. You now know why you should care about this. So let's actually talk about how to do it. I'm not going to be talking today about clinical care tips when you're actually seeing patients. That's a whole nother conversation. What I'm specifically going to be talking about is actual virtual precepting when there's telehealth involved. And here are the key principles. The best part and the first part and the most important part is that one. Telehealth is a new tool for providing care, not a new type of care, which means you already know 90% of it. You already know your clinical skills. You already know what you want your medical decision making. You actually already know how to be a preceptor in the in-person space, which means you've got 90% of this. So I don't want people to come away and say, oh my gosh, I can't remember all this. I don't want to bring students in until I'm an expert. Bring students in, bring residents in, bring faculty in. If you get derailed by the telehealth side, just focus your precepting on the clinical care, on the medical decision making, and that's 90% of the game, and you'll be learning a lot of it along the way. So you really don't need to learn that much more. We're going to talk about the rest of the 10% though for the rest of the presentation here. Tech does vary across care settings, both across health systems, as well as ED, inpatient, ambulatory. When the patient's in a home versus the patient's in a healthcare setting. However, our virtual precepting principles and best practices are constant. So when you're precepting, I wouldn't recommend getting into the weeds of how to use a particular platform. And everything I'm going to be presenting here, even though I might mention ambulatory care, actually goes across all care settings, all health systems. And we do want to teach our learners more tech system agnostic scenarios, because as they go into future practice, they may be working with something else. And actually technology is changing too. This last one is actually very important. So ensure the patient understands the learner-preceptor relationship, and then have upfront discussions of telehealth encounter roles and responsibilities. We're going to be talking about this on the next couple slides, because this is going to be what the patient's perception of the care, particularly when there's a learner involved. It's also going to have a lot to do with the efficiency of how the visit goes down. And I know that one of the reasons why it can be difficult to incorporate learners into telehealth care is because of efficiency concerns. So we're going to talk about ways to address that. All right, this is kind of the overview pie in the sky tips that I would want to take into account. First is actually to consider direct supervision more often than for in-person care for a couple of reasons. One is that learners, even our very experienced ones who are about to graduate from whatever program they're in, are going to have a longer telehealth learning curve, pun kind of intended, because they're actually building on less clinical experience. So they're starting from a different place, and then they're layering the virtual techniques on top of it, as opposed to a 20-year experienced faculty might be starting from a different clinical care space, and then they just have to learn the virtual stuff on top. Also, learners actually really appreciate feedback on virtual patient interactions. They're often not doing as many virtual patient interactions as they are in person, and so you have less opportunities to precept in this space. And if you can watch them, you'll be able to be more effective about this. And then direct supervision actually can have less impact on autonomy, which is, I think, one of the reasons we don't always use direct supervision is because we're trying to preserve that learner autonomy. But in the virtual care space, it's easier to remain in the background. For example, people on Zoom, I can't even see you right now. And so you actually can make it feel like this learner and the patient have more direct interaction. And so this is maybe not as much of a concern as it would be in in-person care. One thing that is really important is to minimize those learner preceptor transition frequency, which I'm very bad at because I'm jumpy, I'm impatient, I move around all the place. But in the telehealth space, those can be very confusing to patients. And you want to be particularly focused on holding confirmation of your key questionable findings and your feedback until the end, so you're not doing this jump back and forth, because it is much more disruptive in virtual care. But we also have a tip here. So you have some technology options. You can actually text, as long as you're not doing patient information, PHI, by the way, on an SMS text. EMR messaging, Epic Secure Chat, that you can do PHI through that. You can send a message to the learner and say, hey, you're going down a rabbit hole, derail, without actually interrupting their thought process. Precepting, you do want to set aside time to check in because you're not going to have that hallway or elevator time when we often do a little bit of teaching on the fly. We, say, hey, maybe work on this. Oh, that was amazing. So you actually want to set in dedicated time. Also, our remote learners, if they're working in different places from their preceptors, they can feel very isolated. And unless they're given explicit permission or opportunities, they might be reluctant to call to discuss a case for something short of something major. And then lastly, when you are precepting, it's always good to talk about workflow steps that are unique to telehealth because they're not necessarily getting that in other environments. For example, get virtual consent at the start of the visit, verify 2 patient identifiers. I have these, by the way, tips all on the last slide at the end, but these are the things that you actually do want to spend a little bit of time on in your precepting space. Is there a smart phrase that needs to be in your documented note? Make sure you teach learners this. Okay. So I mentioned before, setting telehealth roles and responsibilities is important. And the reason for this is because if you have good roles and responsibilities outlined, your patients will understand what's going on, your learners will be comfortable, and you're going to move fast, which in a busy environment, that's important too. If you don't, all of these things are going to feel just a little more awkward, a little bit slower, a little bit more off. And so this is probably the most important part of precepting. It's important, by the way, for in-person precepting too, but it's particularly important for telehealth. The roles and responsibilities are actually very similar to in-person care, but the how differs. For example, are you going to have a camera on? Are you going to be jumping in? Are you going to be doing transition frequencies? The actual roles, though, really don't change. There's still the preceptor-supervisor relationship. There's still direct supervision, shadowing, all those sorts of things. But you want to be explicit and talk about who will do what and when. So which encounter components will be led by the learner versus the preceptor? We'll talk about examples about this in a sec. When will the preceptor join the encounter and or take over from the learner and become direct interaction with the patient? And then we want to communicate these roles to patients. So first we set them in our own minds. Then we communicate them to our learner. We have some conversation about whether or not the learner thinks that that's the right thing to do too. And then we communicate these to the patients. And there are 2 ways to do that. One is to verbalize, always works well. But you can actually also do this with some selective mic and camera control, as I talk about here. So I divided this out into shadowing, direct supervision, and indirect supervision. And then I have a couple of tips here. And in the shadowing side of things, so you actually want whoever's going to be directly interacting with the patient to be focused on the camera. So have them sit in front of the camera if you're side by side, have the person who's less involved over on the side. Notice I flipped it for direct supervision. Now the learner is directly in front of the camera. Maybe the supervisor is a couple feet off to the side. When you're in the 3-way video conferencing space, generally speaking for shadowing, both supervisor and learner are going to be connected throughout. Generally speaking, the learner mic is going to be muted, but the camera is on because you want that patient to know that that person is in the background. Just as in clinic, you want them to know that the student is there. It's appropriate for patient transparency. But because the supervisor or preceptor is going to be interacting primarily, they're going to, of course, have their mic and camera on full time. Direct supervision, it's basically going to be the opposite. Supervisor is going to be connected the majority of time. Most of the time, you want that camera to be on, although there are some scenarios where you might want to, for autonomy reasons, you might want to be in the background with your camera off. Just be very, very explicit to the patient if you join, if you leave, so that they know what's going on, because they always should know who's involved in their care, even in the background. And then generally speaking, whoever's not talking should have their mic muted. And then for indirect supervision, basically your learner is going to start and you're going to join later as the preceptor. So the question is, how, when? Are they going to come get you? Are you down the hall? Do they need to text you and say, I'm ready for you? EMR secure chat, whatever the case may be. And also if there's an emergency, how are they going to get you to? We're going to come back to patient safety. In that video conference though, the supervisor is actually not going to be on this the majority of the time. So the learner is going to have their camera and their mic on full time. And then the supervisor is only going to turn on their camera when they join. And that's going to trigger to the patient like, hey, I'm here, just like walking into a room. And they're going to make sure to introduce themselves on arrival. And again, this is so, as you notice, I'm talking about camera and mic control. Of course, you can verbalize roles to patients, but by using these technological tips, you can also enforce a lot of what you're talking about. And then I do just want to mention that sometimes there might be billing, particularly if you're doing time-based billing or local practice rules that will dictate the need for supervision that's independent of the actual clinical or educational need for supervision. And they might be a little unique to telehealth, so just make sure you know your practice environment. Okay, so that we've done a very successful telehealth visit. We've got our learner, everybody's excited. Now it's time, we've actually set up elevator time, or virtual elevator time, and we want to actually debrief on how things went.
So how do we provide feedback? Well, first thing is there's actually two factors involved. There's the clinical experience, clinical knowledge, and the telehealth experience. And you actually want to focus on both of these when you're doing feedback. Generally speaking, if you're one of those people that does one positive, one negative, or two positives, two negatives, whatever your feedback sandwich is, you're going to be reinforcing those stronger categories and guiding, offering constructive feedback in the weaker of the two categories. And that will depend on where your learner is, both in terms of clinical and telehealth experience. The three things that they actually really want to understand is which patients are appropriate for telehealth care, virtual presence, also known as the website manner, that's patient rapport building, and then remote physical examination techniques. So if you can focus your feedback on one of these three categories, you're way ahead of the game. And then you actually have a unique opportunity that I personally think digital literacy should be part of every social history, because it's not just about can you access telehealth, it's can you access the patient portal? Can you get online to re-enroll for Medicaid or whatever your insurance plan is? Digital literacy is actually a social determinant of health now. And telehealth is an incredible opportunity to talk about that in a way that you might not remember to an in-person care, myself included, actually. So I would, if you have a chance, you have a little bit of time, you want to provide extra guidance, this would be something I think is a very unique opportunity. And of course, there are equity considerations that go along with that. So a little more formally now, let's talk about how we can assess telehealth presence, which is that website manner. It falls into four categories: communication, relationship, awareness, and technical, as opposed to, I think in the in-person space, we maybe just focus on communication and relationship because situational awareness is not that as big of a deal when we're controlling the healthcare environment. And technical obviously is not as big of a deal. But you do really want to try and focus on all four of these. Communication falls verbal and nonverbal unless it's phone only. Relationship, that continuous engagement. Did they try to build rapport? Did they talk about something in the background? Did they minimize distractions? Awareness, this goes back to the roles and responsibilities, addressing privacy. Is there anybody in the background who shouldn't be there? Did they manage to get rid of somebody during an appropriate part of an exam that's actually considered protected and you don't want the spouse to be there? Were there visual cues that were related to social determinants of health? Remember, this is something that you can do in the telehealth space if you're doing home care. You actually can see what's happening in the patient's background. And that is huge. That's something we don't get in person. So this is a unique opportunity. And then technology, were you addressing distractions? Were you messaging it positively or negatively? Because remember, just like in in-person care, patients take our cues from us. And we want to be consistently messaging this positively, even when there are challenges. And then was the learner's background, their appearance, how they interacted with the camera, was that conducive to patient care or was it a distraction to patient care? So again, when you're talking at evaluation and assessment, communication, relationship, awareness, and technical are the factors that should go into that website manner. And I briefly mentioned telephone encounters, but they're unique enough that I think I want to talk about them briefly. So best way to do telephone encounters is either conference calling or speakerphone when you're next to each other. If you are using speakerphone, be aware unless you're really close, like elbow to elbow, one person is going to sound louder than the other, and you might need to confirm with the patient that they can hear both of you equally. When there's audio only input, there are distractions magnified. It's always a good idea to mute, but in this time, it is really important to mute, and it's important to remember whether you're muted or not. Avoid multitasking when you're on, even more so than you should for video. The learner-preceptor relationship is also even harder on phone than it is on video for our patients to understand. So you want to be verbalizing when you're in the background or when you leave because they're not even going to have that visual cue. And then every single time that you switch, every single transition, you want to reintroduce yourself. Doesn't have to be the full introduction, but you do want to reintroduce yourselves because they might not detect on the voice changes, particularly if there's some degree of hard of hearing or other factors. And so you don't want to assume that anybody knows when you're transitioning conversation. You just reintroduce. And then lastly, three-way phone conversations, we've all been on them. They're super confusing, even more confusing than 15 people talking on Zoom simultaneously. So those divisions of tasks and the roles and responsibilities, it's even exceptionally more important on phone only, and definitely hold feedback until after the call ends, unless it's a patient safety issue. Speaking of patient safety, these are a couple things that I just wanted to mention is how are you going to handle an on-screen emergency? For example, a patient starts choking in front of you on Zoom. Those are actually things that we should be talking about with our learners. In psychiatry, specifically, a patient discloses suicidal or homicidal ideation. How are you going to address that? The preceptor, when you're not doing direct supervision or shadowing, should be immediately, and I truly mean immediately, available by either EMR messaging, which means they have to be monitoring it, or by text. Again, no PHI on text, but if you're holding your phone, that might be like, hey, I need you right now. And that's just because the learners, they really need to be able to get you if something really goes sideways. If there's a potentially high risk encounter, for example, a behavioral health patient who you know has chronic suicidal ideation and might be more acute in this phase, talk about that in advance, think about what you're going to do. And then, of course, if there are unexpected events, debrief them specifically with a lens towards that, just like we debrief codes, RRTs in the clinical space or whatever the case may be. Okay, so now that you're experts on this in like 15 minutes, I want to talk about how to actually apply a model called the 1-minute preceptor model to virtual care. And I choose this for a couple of reasons. One is because it really fits in nicely with telehealth, but also because it's really fast. And if you're slowing down already a little bit in virtual care because it's not your preferred comfortable place, fast is good, right? And so I really think this 1-minute preceptor model works out very well. So what is it? Independent of telehealth, these are the steps behind it. Set goals and expectations. Notice that's exactly like our roles and responsibilities. And then after the fact, how are you going to do the debriefing? You're going to get a commitment, probe for underlying reasoning, teach a general rule, reinforce what was done well, guide, and then encourage reflection and integration. So let's talk about how to do that with virtual care. We're going to go through this twice, once for a novice learner and once for an experienced learner. For this novice learner, think about your own practice. I'm just going to offer some sort of acute chief complaint you might manage via telehealth. One example might be you're a PCP seeing a patient with new onset cough and congestion. That's a very common one. But again, think of something in your own practice. Your learner is actually relatively new to clinical rotation. So they're learning clinical and they're learning telehealth. So how are we going to do this? Well, first, before the visit or the encounter or the inpatient encounter, we're going to be setting our expectations. So what I might say is, what I'd like to do, let's do an initial 3-way introduction, who we are in front of the patient. Then I'm going to watch while you perform the encounter. And then I'm going to finish at the end by confirming anything from the history and exam that I wanted to get additional details on. I'll update your assessment and plan if needed, and then I'll summarize the next steps for the patients, and then we'll move on. Both of us will mute when we're not talking, and both of us will keep our cameras on throughout. So I just set my roles and responsibilities. And then I would, of course, ask my learner, does this feel comfortable with you? Any other thoughts you might have? All right, so now we're going to go do our telehealth encounter. It went exceptionally well. And then we're going to come back, and we're going to debrief. So when I get a commitment, I probe for a reason. What I might say in my URI example, do you think this patient has bacterial pneumonia? What did you identify that makes it less likely? And then I'm going to teach a general rule related to that. So I might want to review signs of moderate to severe pneumonia that can be assessed via telehealth. And notice I'm picking something here in my general rule that speaks both to clinical care as well as to telehealth care. So signs of moderate to severe pneumonia, and how am I going to get that on a video exam? So if you can pick a general rule that hits both of those, even better. And then I'm going to reinforce and guide. And what I might do, because this is a very new learner who is very digitally savvy, I'm going to reinforce in the telehealth space, and I'm maybe going to guide in the clinical space. So your telehealth presence and lack of background needs made it super easy for the patient to stay focused on you. I was really impressed. And I just wanted to mention, when I have a patient with URI symptoms, I always assess for dyspnea and tachypnea because they would be pertinent negatives when I'm trying to rule something else out. Do you see how I'm going with that? And then lastly, encouraging reflection. So did you get the data you needed to determine this patient has a simple URI that doesn't need antibiotics, doesn't need an ED visit? Easy peasy, right? Okay, let's talk about how we might do this with an experienced learner. So again, think about something in your own encounter, the one I'm going to offer here. Let's say you're a surgeon doing a post-op home video visit for a patient with limited mobility and transportation options. You're not expecting any major concerns, and you know it'd be very hard for them to get to clinic. Your learner is just about to graduate from residency and going on to their own practice. So here, now I'm setting my expectations very differently. So what might say is, I would like you to start the visit alone, secure chat me on Epic when you're ready for me to join you. Once I join, I would like you in front of the patient to review your findings of basically what you talked about with the patient. I'll add any things that I feel at the end, and then I'm going to verbally hand the encounter back to you so you can close it out, address next steps, and move on with the patient. So we do that. Encounter goes great. And then we're going to debrief at the end. So what I might say here, when I'm getting my commitment probing for reasoning, are the incisions healing appropriately? How did you determine this? Did you ask for a photo if the video quality was borderline? When I'm teaching a general rule, again, I'm hitting both the clinical and the telehealth side if I can. So I might want to review signs and symptoms that would warrant urgent in-person evaluation. For example, signs that you could assess on video of an infection that warrants, again, immediate intervention. In this case, this person probably has very, very good clinical skills. They're just about to graduate. Hopefully they do. So I might be guiding in the telehealth space, the virtual rapport building space, and reinforcing on the clinical space. For example, that was a great stepwise discussion of pain management. I would, however, consider focusing your eyes on the camera lens rather than the patient's on-screen space to help you build that great patient relationship. And then in encouraging reflection, how might you use telehealth after graduation when you're no longer in this learning space? So 1 minute preceptor rule, novice, experienced, see how it's different, and really fast. Okay, so this is going to be our summary. The first two I think are probably the most important thing. If you wanted to take home anything from this presentation, is that virtual care will be a part of our learners' future practice. We do have an obligation to teach it. And again, I don't think that that's just my bias. There's a lot of organizations external to me that are saying the same thing about this. At the same time, learners have much more experience with digital relationships than most of our faculty, myself included. And so we actually have an opportunity to learn from them. This is bi-directional. And by the way, learners love teaching faculty. So if you can just like take home these two learning points, and again, don't be afraid to get comfortable in that virtual space because you already know 90% of it. A little more specifically, use your in-person precepting knowledge and experience as the foundation for your virtual precepting. Just add on to it. Definitely spend time on those roles and responsibilities with your learners and to communicate them to your patients because it will make everything go so much better. And then focus your feedback on which patients are appropriate for telehealth, your virtual presence, and your exam skills. And lastly, we are all learning in this. I mean, if you think about it, it's only been 2 years since this massive explosion. We are honestly all learning. And so you just can't go wrong. You know the clinical care space, so just do it. It's okay. You'll learn along the way, and hopefully these tips will help. This last part, I'm not going to talk about this. This is basically just for your virtual back pocket. So here you have a bunch of pearls that you can stash away for further use, and you can share them with learners. Feel free to cannibalize them, take them, share them, forward them. I don't care. So with that being said, any questions?
All right, we've got folks on Zoom and in the room, so we can take questions either way. Dr. Olson, thank you so much. That was fantastic.
Jen, so you're going to do the Zoom questions?
I'm going to do Zoom.
and
You
then-
do the room.
Okay,
I'm
great.
Scooting
And
back
then
here to see if
Riley.
they're any in the
Okay.
chat.
All right, sounds good. Sounds
Anyone
wonderful.
here? Eric.
I'll just talk directly. So my name's Eric Young. I run the LIC at the VA. A question that's come up for us that was we're sort of building pool of preceptors, particularly in psychiatry, where I feel like we've seen a bigger than anywhere shift towards telehealth, is thinking about what that means outside of just the individual encounters, but what that means for a longitudinal relationship between a student and a faculty, and trying to wrap our minds around, like, could they have a year-long longitudinal relationship that is all virtual, and or like should there be some time outside of that they meet in person and they build these rules? Do you have a sense of that kind of bigger picture? Because it's sort of, I think, going to become a reality in places where we need preceptors that they may only do virtual work. So thoughts on that?
Yeah, so the question is about virtual versus in-person. I would actually I would separate it into two separate questions, even though I know it probably is being discussed as one. One is actually, what does the patient need? And at first, there are some patients that they will do exceptionally well on 100% virtual. In fact, they'll do better than with in-person. There are patients who they'll do virtual care only when it's really hard to get to clinic, but they really actually do better and they get a better treatment in the in-person space. And so I think that actually needs to be question number one, is what's actually best for that individual patient, and make sure you are matching that. Once you've decided that, assuming that it doesn't matter for the patient, and now getting into the preceptor side, I actually think that it probably doesn't matter for an individual patient, but probably students should get comfortable in both spaces. And so if you have a student that's only working with a virtual preceptor, they might actually not feel as comfortable in that in-person space. In fact, we've seen a little bit of that in the beginning of the pandemic. People spent so much time virtual, then they went to in-person rotations. They're like, I don't know where to start. And so I don't necessarily know that you need to have each student with each patient flip back and forth between in-person and virtual, but I do think it's important that they get a sense of both spaces. And then what you do for an individual patient, I would say probably needs to be driven more by the patient than by what the preceptor student or learner relationship is.
So I think I'm hearing like if a student's paired with psychiatry preceptor that does only virtual psychiatry, that may not be ideal in the sense that that student never does the in-person component. And so really trying to make sure that there is some balance of those two.
I would think so, unless you see a scenario where that student in their future practice will never have to do in-person care. And I think that that's pretty uncommon because there are differences about how you build rapport, how you control an environment, how you control visit workflow or inpatient encounter workflow in the in-person space that they do need to learn too.
And do you think it would be valuable for that preceptor student pair to be carving out in-person, doesn't have to be clinical time, but like in-person time that they're building their own relationship that is not purely virtual? Like, is that
You mean between the preceptor and the learner?
and the learner? Yeah. Like, is that, it's like, it's almost an extra ask for a preceptor, but I feel like it's probably an important extra ask. Just 'cause-
I think it would be a nice to have. I wouldn't necessarily say it's a must have. I do think teaching people how to do in-person care is a must have. And then from there, I would probably say what works for that preceptor and learner and the circumstances they're in. If you can, I would. But again, I would put that in the nice to have as opposed to the must to have.
Great, thank you.
Okay, we have one question in the chat here, which I think is a great one. Someone's asking if you could provide some examples of how you ask about a patient's digital literacy. I think this actually comes up in the realm of health literacy too. It's sometimes hard to ask these questions.
Yeah, so how you ask about digital literacy, that's like a whole fun topic. I mean, I could go on for an hour on this. Sorry, I'll go a little closer to the mic. So I just mentioned that is a very, very big topic. I think that a couple of really quick questions. Do you have internet access? You could even say, hey, have you ever done a telehealth visit? If I'm seeing some in the in-person space, would you like to do follow-up by telehealth if I can arrange it? And I actually have done that as a hospitalist. And sometimes patients say yes, no. One of the probably the best screening questions is, do you have patient portal access? And can I get you on that? Because that is the entry point to a lot of technologically enabled healthcare. Also, with that one question, are you on our patient portal? You're screening for internet accessibility. You're screening for digital hardware device capability. You're screening for a moderate degree of digital literacy, just because those are requirements to get on the patient portal. So if I had to pick one question, that would actually probably be the one. And then I would go from there, depending on the scenario.
Thank you.
Any questions from the room?
So for a number of our students, they'll also be documenting these encounters. So do you encourage or discourage simultaneous documentation while they're talking with the patient? How do you kind of navigate that with the students?
Yeah, that's a hard one. I think that it depends on their degree of comfort. And I would say this is probably actually true for in-person care too. I would discourage somebody from documenting while providing an encounter until they're very comfortable in that encounter. Because the more things you layer on, the less they're going to be focusing on the encounter itself. So if you've got somebody that's really experienced in the encounter and you know you need to, and they're getting towards the end of training, whatever that is, and you want to start getting them to work on efficiency, you might want to, with one caveat that I'll get into a sec, but I would make sure that they're really confident in their clinical care space before we start talking about documentation. And again, that's true in the in-person space too. We all know somebody who spends all their time on their computer, faculty included, and it's very distracting to the patient relationship. So we want to model good behavior and good practices in that respect. The one exception that I will put out there is that when you have somebody who's typing, if it's very close to the microphone, it can be exceptionally distracting. We've all been on those Zoom calls, meetings, where you can just hear somebody going bang, 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 bang. And some of that actually depends on what type of typer you are and what type of keyboard you have. So that goes back to knowing, is what you're doing, is that distracting? It's not just, are you making eye contact with the camera lens? It's also, is your background noise under control? And this is something that you can help if you're directly supervising and you're assessing for website presence. Obviously, if it's distracting the patient encounter, you might want to teach them how to be more efficient, but they shouldn't be doing it because the patient encounter takes primacy. If it's not, and they're very comfortable and you think they can multitask effectively, then I think it's a good skill to teach. But again, always go back to, is it going to interrupt with the patient encounter? Because that really does need to be the first part. That's true for, by the way, for faculty too. I do actually recommend for people that they have to be aware of their keyboard noise. And if they do have keyboard noise coming across, you should not be documenting even without a learner. during your visit.
I have a question. So the website manner, that one that had your slide that had the green bars at the top, that's so rich in things to work with learners. And I'm wondering, do we know if the medical school is working on how to teach that early, like in a more formal way than just doing it with me in my clinic, which I will teach them some things, but it seems like those were really rich bullet points about what you can do to make sure that you're connecting well, and make sure, like I've had examples of, I'll go see a patient with a resident, even a senior resident, and the patient is in bed at, on the telehealth visit, and it's unclear to me and it's unclear to them whether they're in bed because they just like being in bed, or whether they're too sick to get out of their bed. And so have had discussions about, you must position your patient so you can tell if they're dyspneic, and things like that. So I'm just wondering if there's a more formal way of teaching the medical students before they enter residency.
Short answer is I'm working on it. So that is actually my telehealth curriculum director role, which I've been in for a year and a half now, of integrating into a longitudinal curriculum, which is getting there. In terms of the medical students specifically, in the ICC or base camp that was going into that core clinical year, we were doing a workshop about an hour and a half on this with an asynchronous module that's been going on for about a year now. It's probably going to be moving a little bit. There's also actually an interactive discussion with the students on telehealth and equity. Again, it's going to be moving a little bit of place. I have other ideas about how we can bring this in even earlier in the curriculum. This is still somewhat under development. So short answer is yes, to a certain degree, but maybe not in the beginning of the first year. So if you're precepting someone early, they might not have gotten that. Working on it. In terms of the resident and fellow space, I think that that's something that residency program directors, fellowship directors, there's a lot of core content out there, and I'm happy that you steal any of this and adapt it, and or go to your board or go to your curriculum for your residency and integrate it in, because I do think it's important for residencies and fellowships to start teaching that. We are doing it for the pediatrics residency starting again about a year ago with an academic half-day session.
Awesome question. It was almost like we planted Linda to ask that. That is something I think we've been working really hard on in the School of Medicine, recognizing this is not a skill that students arrive with, but something we need to build towards. So there's another question in the chat. Rural preceptors would probably love a video course on telehealth techniques they could do over a 1-hour lunch with students, since they often both need to learn this together. I think that's a brilliant idea. What are your thoughts on that?
In the short term, I would be happy to reprise this for any faculty groups that want to do that, and we can do this over Zoom. In terms of other stuff, I might be able to come up with some online content that we can disseminate. There's a lot that's out there. I think it does depend on the specialty, which is why I tend to say I send people to the specialties that they're working within. But in terms of some of this, I'm not aware of like a 1-hour video that you can go through. It's more stuff that I've developed and or friends have developed for live presentation. Good idea though.
Yeah, I love it.
And we have one in the back.
Yeah, I was wondering, I think the students actually do really
Yeah, so now we're getting into other aspects of telehealth that aren't just video visits. And for the purpose of this presentation, I didn't go there, but you're exactly right. That is very important. Even like photo interpretation in dermatology, things like that, e-visits where people do symptom questionnaires, and then just the simple patient portal messaging. So I do know that in one of the TBL cases, I managed to insert, in conjunction with the internal medicine, we inserted some patient portal discussion into one TBL case. To my knowledge, that's the only place it's being formally taught right now. I think a lot of this goes back to preceptors. If you can encourage students to work with you when you're working through your messages, they'll be learning along the way. And I think that often what we do is we say, okay, you go work on your notes, I'll work on my messages. And we're probably doing them a disservice by doing that. It is more efficient. I'm not necessarily saying to do that all the time, but it's actually important for our learners to know what we're doing in between direct patient interactions, because that is just as much part of practice, if not even more so, than what we spend with our time in front. So first answer, I would actually say incorporate your learners in the time you're doing it, even if it's just shadowing, and they'll learn by osmosis. Maybe explain how you're mentioning something, why you're referring this one back to in-person care, why you think this is easy. But first step is actually just to include them in that part of our clinical care. And you're right, we need to work on that too in the formal education.
All right, another question from the chat. Someone makes the comment that it feels pretty intrusive to ask someone to show you their home while doing a visit. How do you approach that? Is that just sort of what you notice in the background, or do you actually ask specific questions?
You know, I actually got an echo. Can you just repeat that?
Sorry, I may be holding it too close. Is that better? I'm going to shove this down my throat. A comment about how it feels pretty intrusive to ask someone to show you their home. Is that something you just observe in the background, or do you actually ask to see specific things when you're trying to assess that as part of a telehealth visit?
So I think it depends on the scenario, and it depends on the reason for the visit. It also depends on whether I know the patient or not. I think a good step actually is to start with rapport building. And the best way you can do that, I'm a pediatrician, so we'll do pediatric stuff. If I see a stuffed animal in the background, I'm like, oh my gosh, can you introduce me to your stuffed animal that I see there? I see like that giant Elmo. Does he have a name, or is his named Elmo? And then that's a natural entree into, oh, I see this, I see this. So it's not like I'm spying on them. I'm telling them that I see something really cool. And that's actually what we do in person, or at least I do in pediatrics. If I see somebody with a really cute stuffed animal in their bed in the hospital, I usually ask about it because it's part of my rapport building skills. If they've got cool nail polish on with a bunch of glitter, I'll actually ask about it, and it actually makes the exam part easier. So I think that probably one way is actually to incorporate it as rapport. Think of it as rapport building as opposed to scoping out their house. There are, however, times to, quote, scope out their house, and that gets into your social history. I think probably the best answer is to be transparent. And when you notice something, bring it up. Ask about it. But again, use it in the sense of, like with all things, of curiosity as opposed to judgment. This looks really interesting. I didn't know that you had this in the background. Wow, you have so many things on the counter. It must be really hard to find your medications. See how I'm going with that? Clutter, but at the same time, I'm focusing it on something that's clinically relevant. So again, I think it's, curiosity as opposed to judgment, and just check your judgment at the door, which means check your own biases about what you might see in the background at the door. One thing that I didn't bring up, but is important for that safety side, you are still a mandated reporter in the virtual health space. And this is something that you do want to be talking about with your learners. If you do see something that meets the category of mandated reporting, you do need to report it. It can be a little harder to assess. And so if you're not sure if it meets that level, you do need to ask the questions. And you also need to be aware if there's an unsafe situation in the background that you're going to be talking about. So that is a patient safety consideration that you should actually be discussing.
Thank you.
Can you hear me? There it is.
Gotcha.
Would you want these encounters to include not only video visits, but also like phone visits? Because I know like a lot of practices not only have just video capabilities, but a lot of their they actually have phone templates built into some of their daily schedules as well.
So I think this goes back to the patient portal and kind of where I started with this. Whatever you think is going to be a part of your learner's future practice, I think should be taught somewhere along their learning journey. At the same time, the more moving parts you incorporate, just like in in-person care, the more complicated it's going to get. And so you might not want to add all modalities of clinical care, virtual and in-person, all simultaneously, especially if you're still learning them yourselves. I would just, though, try and make sure that you hit at some point on their learning journey, maybe not in the beginning. Now, if you're completely savvy and you can flip back and forth between in-person, phone, and video at will, and you feel equally confident in all three of those spaces, by all means, bring the learner along for the ride. Maybe the first visit, get them comfortable, because they also have a learning curve. Get them comfortable in one or two of these spaces, and then do an additive approach as opposed to throwing every aspect of virtual care at them simultaneously. So long answer, but what I really want to say is that by the end of their learning, yes, I think they should get exposed to all of it and they should learn all of that. Whether or not you do it all simultaneously may or may not be the right choice depending on where they are in their learning process.
One more in the chat. Is there, they just keep coming. Is there a resource for the management of emergencies while on a telehealth visit?
Ooh, that's an interesting one. In terms of an overall resource, no, there's not. If you work at the Children's Health System, the telemedicine policy for medical staff actually does include a 3-line item that basically says you should stay on the video connection until you're no longer needed. Don't disconnect. Just if you're in the background, EMS shows up, stay in the background, ask if they need anything, provide handoffs. So we actually do talk about that briefly with faculty. I do think the other part in psychiatry, I know a lot of psychiatrists will confirm the physical location of the patient at the beginning of the visit. One nice way to do that is, I just want to check demographics at the beginning, like is this still the right address? Where are you located? And that's a non-biased way of figuring out where they are. And for the reason for that is if you have to call 911, you can't say, I've got this patient on Zoom, can you respond? That's not going to go over very well. You actually need to know what physical address. And so high risk visits, it is a good idea to actually confirm physical location of the patient before you get started. And again, there are ways you can phrase that as a demographic question without getting into the real reason as to why. For the learner side, whatever we can do to model, this is more faculty training, but whatever we can do to model these things for our learners is a good idea. And then I think the other key point to bring across, as I mentioned before, is if something bad happens, the natural tendency might be, let me disconnect because I'm a distraction. That's actually not what you want to do. Remember, you're only on a little screen in the background. You're not as big presence as you think you are in that room, that physical space. So just do whatever you think is appropriate for your scope of practice in the scenario, but don't disconnect.
That's great advice. Thanks. All right. Well, I think we are getting close to time. This has been enormously helpful and informative. Thank you so much, Dr. Olson, for your time today and your expertise. Lots of comments in the chat about how an hour-long lunch session would be helpful. So we may have to hit you up for that as well. Thank you so much for your time today.
Yeah, sure thing. And again, happy to reprise it. Just please consolidate so I'm not doing it 70,000 times.